Good afternoon, everyone. My name is Elinor Slomba, a member of the Red Rock team who works with the APT Foundation to bring the wonderful message of their work in substance use disorder treatment, prevention, research to the community. And along with all the wonderful treatments and wraparound services, of course, they have a long legacy of research. So we're focused today with Dr. Declan Barry, who has specialized, chosen to specialize in the area of chronic pain as it relates to substance use disorder. He's also a licensed clinical psychologist, associate professor in the Department of Psychiatry and in the Child Study Center at Yale School of Medicine, and of course, the research director at the APT Foundation. So of course, you're going to be hearing a lot more from him than from me today, but just know I'll be happy to pass along any questions that you don't, but you will have a chance to ask them yourself if you want to drop them into the chat at any point during this talk, or raise your digital hand, and we certainly will make this quite interactive. But without further ado then, Dr. Barry, I'll turn it over to you.
Great, thanks, Elinor. And it's a real pleasure to present to you all today. Like Elinor said, that I'm very pleased to be the research director at the APT Foundation. It wasn't that long ago that we actually celebrated the 50th anniversary of the founding of the APT Foundation. And one of the giants in the field of substance use disorders, Herb Kleber, set up the foundation largely to have a place to conduct research on people who were addicted to opioids. And I'm glad to say these 50 years later that we're still continuing to do research at APT on folks who have opioid use disorder. You know, if we were back 50 years ago and we were talking about, you know, the epidemic that was happening back then, it might have been, you know, people who were coming back from the Second World War who primarily were taking heroin. Then if we were to move forward another 10, 15, 20 years, it might be soldiers coming back from Vietnam who became the face of this opioid crisis or epidemic. Now we're at a position where we have many, many more people who are addicted to opioids. And the topic of today's conversation is around chronic pain and opioid use disorders. And it was, you know, one of the ways that this face of the opioid crisis has changed is that back in the 1990s, largely in response to a large untreated group of people who had chronic pain, that Purdue Pharma in our own home state here were granted by the DEA a license to produce OxyContin. And at the time, it was reported by the pharmaceutical industry that these medications would not lead to an increase in opioid use disorder or opioid addiction. That assertion did not prove to be accurate. So back in, you know, roughly 2000 or so, it was around 500,000 or 0.6 of 1 million people were thought to be addicted to opioids. Now it's at least tripled. And more it's been recognized that the role of opioids in prescribing or in addressing chronic pain led at least some people, and estimates suggest it's probably around 10% of people who were prescribed opioids who later went on to having an addiction. And that's going to be the topic of what I'm going to discuss today. So we're going to look at chronic pain and opioid use disorder, responding to a complex picture. It's always good to have a origin story. And we didn't actually start in a garage like some of these tech companies did, but we started at 495 Congress Ave back in 2008, which is the downtown location of one of the main clinics of APT that Kathy Eggert runs. I've got the pleasure of having an office in this building. Back in 2008, we decided to set up what we call a pain treatment services. And there were a group of us who were interested in finding out more about patients who were coming into APT who not only had an addiction to opioids, but also seemed to be experiencing chronic pain. And in this picture on the left, you can see a woman dressed in black. Her name is Lana. She was our first intern. She's now a clinical psychologist. Next to her is Mark and then Chris. And these are the original research director of the pain treatment services and clinic director. I'm fortunate to say that they're still with our team. Then Dawn, who is a postdoctoral fellow. She is now an assistant professor in Harvard. Then it's me, and then the guy on the right was one of our research assistants, who is now a surgeon. He went on to medical school, and in part I'm putting this up because it's an interdisciplinary team, and then also one of our main foci is around training, and we've put a lot of effort over the years into trying to train up not just individuals who work at the APT Foundation and how to assess and address pain, but also a whole gaggle of addiction psychiatry people, nursing people, social work people, all in an effort to try and understand more people, the concerns, and to address also the concerns of people who've got co-occurring chronic pain and opioid use disorder. So at Pain Treatment Services, we've got three parts to our mission. One is research, which I'm going to be going over today and just giving you a flavor of what we've been up to since around 2008. And then, as I also alluded to, we also have a training mission. And then also we have a clinical service division where we try and develop treatments that can be used in real world settings like the methadone clinics at the APT Foundation. So in this slide here, it's just reminding us that a large portion of individuals have chronic pain. The CDC estimates that around 25 million Americans have chronic pain. So this is pain that's lasted 3 months or more. Unlike with acute pain, so if one of us, for example, were going out to our cars and we tripped and sprained our ankle, and it was really sore and we went to a medical provider, they could probably tell us something like, well, your pain's going to go away. Pay attention to your pain, that if your pain gets worse, you're probably doing something that's going to exacerbate tissue damage. And if you do what we say you should be doing, it's highly likely that the pain will go away. 3 months later or 6 months later, if that person is still experiencing pain in their ankle, that would now be termed chronic pain. And unlike with individuals with acute pain, people with chronic pain, the amount of pain that they experience is no longer linked to the original injury, and it's no longer even linked to the impending tissue damage. So it's kind of like a faulty fire alarm. And if you can imagine them being in pain, and the pain that you're experiencing is not maybe an accurate signal, plus the fact that there may be a lot of people who are questioning, why do you have this pain? Why has it lingered? Why hasn't it gone away? And that there's no objective measure of it, that you have then a lot of people who have suffering that go along with this ongoing pain. Then this Venn diagram, it's not drawn to scale, but there are a smaller but still significant number of people who have an addiction to opioids, or what's often called an opioid use disorder. And the subset I'm going to be looking at are the folks who have both. That is to say, they have chronic pain and they have opioid use disorder. Now, you might think that there are lots of settings where people with chronic pain and opioid use disorder can go and get treated. It turns out not to be the case. That traditionally, if somebody had chronic pain and they went to a pain clinic, and if they had an addiction, they were told, go and get your addiction treated first, and then come back to us and we'll deal with your chronic pain. In substance use disorder treatment settings, individuals who are working there traditionally have not been trained on how to manage chronic pain. So you get a large number of people who have both, and their needs are probably not being met all that well. So one way then to try and address this problem is to look at people who are coming into treatment for opioid use disorder. And in the United States, the two main evidence-based treatments comprise what's often called opioid agonist treatment. And this is treatment either with methadone or treatment with buprenorphine. And the idea behind these treatments is to prevent a person from going into withdrawal and to prevent them from getting euphoria if they actually do go out and use an illicit opioid substance. When we started off then back in 2008, we did a whole series of studies at the APT Foundation, which we published and presented at lots of different conferences. And essentially, what we did was a series of what we would call need assessment studies, just to figure out, well, what's going on with these individuals who've got co-occurring opioid use disorder and chronic pain, and what are the experiences of the clinicians who are treating them? The things that we found in these early studies were that there's a high prevalence, that in the general population, you might expect around 10% of people or so who've got chronic pain. And in fact, if you look, it's not just in the United States, but if you look in Asian countries, African countries, European countries, the rate is around 10%. And it's usually back pain. And back pain happens to be one of the leading causes of disability worldwide. And if you haven't experienced back pain already, you probably will at some stage in your life. And for most people who get back pain, they have the luxury that it doesn't linger and that it doesn't last longer than a couple of weeks. But with these people who've got chronic pain and who have low back pain, it tends to last for months and years. So many of the patients, for example, that I treat have had pain for 20 years, 30 years, and the pain just hasn't gone away when they started the treatment with me first. Then you might wonder, well, what's the prevalence then of chronic pain among people at places like the APT Foundation who are on buprenorphine or methadone? And it turns out the rates of chronic pain are around 37% to over 60%. So a large number of the patients who are coming in for opioid use disorder have co-occurring chronic pain. Now, you might kind of think, well, so what? That does it really have any impact on their clinical picture? And it turns out that when you compare people who are on methadone or on buprenorphine who've got opioid use disorder, and you compare those people who've got chronic pain and those people who don't, that the people who've got chronic pain report things like that they use a whole variety of substances to manage their pain. They tend to have higher rates of anxiety, depression, PTSD, or post-traumatic stress disorder, trauma, both physical trauma and sexual trauma, than those people who do not have chronic pain. They're also more likely to experience stress. And when they do experience stress, they're more likely to experience it in their bodies or somatically. And then they have a whole range of other clinical vulnerabilities. So things like alexithymia. And alexithymia refers to the inability to report to other people what's going on inside of you, right? So if you can imagine then having chronic pain or pain going on inside of you and people asking you to explain or describe it. There are many people who've got chronic pain who also have alexithymia and who have difficulty putting into words their actual experience, which probably makes them even more vulnerable in some ways. Then individuals who are on methadone, for example, who have chronic pain in comparison to their peers who don't have chronic pain, are more likely to be homeless. They're more likely to be on disability. So overall, they're a more at-risk, vulnerable group. And we've also found things like that they're more likely to have sleep difficulties, that they're more likely to have insomnia than methadone patients who don't have chronic pain. And all of this suggests to me that, okay, they're a more vulnerable group in some ways, they're more distressed, and they maybe need some treatment for it, but I'll also maybe suggest that there are multiple ways of intervening with patients. And that even though many of the patients who start working with me, for example, have this, what I would call a prism of pain, where they start off by saying something like, well, you need to address my pain before my anxiety is going to go down. You need to address my pain before my depression is going to go down. It turns out that these are two-way streets, and that if you can address the anxiety, the pain is likely to go down. If you can address the depression, the pain is likely to go down. When we've asked them also, even though you're coming into programs that are specifically designed to address opioid use disorder or opioid addiction, if we were to offer you treatment for your chronic pain, would you be interested? The vast majority of those who say they have chronic pain report yes, that they would. Then we did a number of studies where we thought, well, it might be interesting to find out from clinicians who are working in methadone clinics, and also clinicians who are working in primary care or office-based settings, which is a typical setting where buprenorphine, for example, is prescribed. We did a number of qualitative studies where we asked counselors at the APT Foundation, physicians who were working in office-based settings in Southern New England about their experiences treating people with chronic pain, and the answers were remarkably similar. We found things like that the providers often didn't like these patients, that in part they didn't like them because they didn't know what to do with them. They had difficulty assessing the pain. They had difficulty figuring out what to do with the pain. When they would ask patients things like, have you tried A, B, or C for pain? Patients would often shut them down and go, yes, I have, and what you're offering isn't helpful. Then they often reported that when they would try and refer these patients, so for example, if there were clinicians who were working in a addiction treatment setting, when they tried to refer these patients to a chronic pain clinic or a chronic pain provider, that the providers often just wouldn't accept them, in part because I would imagine the insurance, but also increasingly since the beginning of probably the mid 1990s, although there's been an increase in the number of pain clinics across the country, those pain clinics have largely focused on opioids and medication for the treatment of chronic pain, or surgeries or interventions. And probably one of the main reasons for that is follow the money. That's what tends to get reimbursed. But again, when we ask these clinicians, well, would you be interested if there were a treatment available to treat these patients if we were to train you up? And they said, yes, they would. Because when they tried to refer these patients to specialists who treat both, they found it very difficult to find them.
Then before we go on, could you please
Yes.
report that statistic again about how many people in the APT Foundation also are reporting chronic pain?
So it's in our studies, it's been somewhere between 37 to 60%. So it's a large number of people. And since we've done these studies, other groups have started doing similar types of studies, and they've reported similar rates as well. Right?
Wow.
So this is a large group of people.
Right. We do have one digital hand up now. Would you like to take it or hold?
Sure.
All right. Well, thank you very much for the very, very nice lecture so far. I have a question about what are the top 3 medications for addressing chronic pain?
That's a great question. So if you look at, for example, at the Veterans Administration, or you look at, outside of the Veterans Administration, for years it was opioids, but then there were increasing concerns, which probably started at the VA because of the high rates of overdose and the high rates of suicide. And now there's been efforts by the CDC not to use opioids for chronic pain, right? And there's been some evidence that the rates have been going down. Even there's also evidence that there it's easier said than done. If I'm, for example, a patient and I've been on opioids for years and you try and taper me down, a study came out, for example, in JAMA a couple of weeks ago suggesting that there's been an increase in people overdosing who have been tapered from these opioids, who were on chronic opioid therapy. There's then groups of medications that are called adjuvant medications. So there's one group that's probably like antidepressants. So SSRIs and SNRIs are often used. Then probably around 6-7 years ago, there became an increasing trend to use anxiolytics and also benzodiazepines. But now there have been concerns about benzodiazepines, right, and how safe those are. And then probably acetaminophen, right, and high doses of that are probably the mainstay of what people are using. In part, it probably says something maybe about our culture as well, that in other countries, for example, there was no opioid crisis despite similar high rates of chronic pain, right? And it's worth looking at other countries and how they manage chronic pain. And one critique might be that they don't medicalize it as much as we do, right? And that if you look at, for example, I grew up in Ireland. When I grew up, people expected to have pain. As people got older, you expected that people would have pain, and you were just told, put up with it, deal with it, right? There was no opioid crisis in Ireland because physicians just didn't prescribe it, right? And they were highly suspicious of that people would end up with an addiction. And in part, as an aside, I would suggest that one reason for that is that unlike most countries, in this country, the pharmaceutical industry can directly advertise to patients, whereas in a lot of countries, that isn't the case, right? And that in a lot of countries, if you look at, for example, the evidence-based treatments for low back pain, the main one is exercise. So that if any of us have low back pain and it's only been lasting a week or two, the key thing that the American College of Physicians recommends is stay active. Right? But there's not much reimbursement for that, right? There's more, right? There's more reimbursement for saying, let's prescribe a medication. So even though then there are these adjuvant medications, and it's somewhat controversial about simply relying on a medication. And if you look at probably the gold standard, which fortunately does occur in many parts of the VA system, but not outside of the VA, is interdisciplinary chronic pain, right? And then you'd have one key bucket would be medication, another would be exercise. So it would be physical therapy, occupational therapy, getting the person moving. Another would be stress reduction, either like meditation, relaxation training. And then another would be maybe psychological treatment, right? And at interdisciplinary clinics, and they have probably the most success out of all the pain treatment approaches. That's what they try and do. And they usually try and combine at least 3 of those.
Yeah, I was going to comment that if the chronic pain treatment happen to be opioids, it's going to be very difficult to address chronic pain at the same time the OUDs, opioid use disorder. How do you convince the patient even to receive treatment? You have to have an effective alternative to relieve the pain in order to get them away from opiates.
And in part then, and that's going to bring us on to the next slide. And please come back to that question if I don't address it by the end of this, right?
Thank you.
So what we've done, and this follows up from what Ming said. Well, what do you do then with somebody who has, who's on methadone for opioid use disorder? They've got chronic pain. They've got all these other psychiatric problems, medical problems, and they're telling you that they're using a whole slew of different substances. Oftentimes, it's not just the opioids, but cannabis, alcohol, also even like nicotine to help manage their pain. And one of the ways that we've come at this is by using cognitive behavioral therapy. And the focus of the cognitive behavioral therapy is not on the pain intensity, but on functioning, right? And essentially what we do is an elaborate pitch to the patient where we try and convince them that rather than focusing only on their pain intensity, which they have little or no control over, that instead what we're going to be focusing on is how it's interfering with their functioning. And we go over a whole set of skills that try and figure out, well, how do you deal with stress, like with relaxation training? How active are you? How do we get you moving? If people are reporting, oh, I'm afraid that if I move, that I'm going to hurt myself, that we actually try and help them understand what these thoughts are and to help them pull back and analyze their thoughts, and that we actually expose them to exercise on site, and that we try and figure out as they're exercising what they're telling themselves. We've done now a couple of trials where we've used methadone or buprenorphine, we've used cognitive behavioral therapy. One was in a methadone clinic, the other was in an office-based setting. And essentially the upshot is that CBT seems to be quite good, that it seems to break the link between a person being in pain and turning to a substance to manage their pain, and that the absence rates from substance use are dramatically higher among the people who get CBT in comparison to treatment as usual. One of the problems though with CBT, especially individual CBT, is who's going to do it, right? And that's one thing in a research study coming up with, 12 different, having people come in for individual sessions or 12 individual sessions. You can do it probably at the VA and some selective medical clinics, but in frontline clinics where people aren't getting reimbursed for it, is there a way to package that so it can be offered in groups? And we've tried to do that over the years as well, where we've done things, for example, like with exercise, that we found in our early studies that the people who've got chronic pain, only around 10 to 15% were regularly exercising, and that their rates of inactivity were much higher than the rates of methadone patients without chronic pain. So we started doing things like extra games. So we had them use the Wii Fit, and patients reported that they got distracted while using Wii Fit and didn't focus on so much on their worries about moving. So we've done a whole different studies than what Wii Fit. We've also had Tai Chi instructors who've come in, and patients seem to like that, just a general movement, slow movement, and that Tai Chi can be used as a martial defense as well. We've done things like train patients, like you might see with Buddhist monks or Catholic nuns, to go out and walk and meditate around the clinic. We've also done groups like relaxation training. Since there are probably some people who don't like talking at all, we've tried out auricular acupuncture. There's some proportion of patients who are miserable. And what we've tried to do is come up with non-drug interventions that might increase their pleasure. So one stage, for example, we ran singing groups where we had people come in and they sang together. And there were people in that group who smiled that I hadn't seen smile in years, right, when they were singing. So these are, and what we've done then is kind of captured before and after attending these groups, what's going on with their pain, what's going on with their anxiety, what's going on with their mood. And that even with these kind of interventions, you see an acute improvement when people come to these kind of groups, suggesting that there probably are things that we could be doing at our clinics that might help these patients that don't necessarily involve even something like individual CBT or cognitive behavioral therapy.
What is auricular again?
Yeah, so there's actually, when you think about traditional acupuncture, and if you went to China or somewhere, probably what you would get is, all people putting needles or licensed professionals putting needles in different parts of the person's body, and they would follow, Chinese medicine. There's a version of that that's been developed for people who are on methadone. And rather than being all over the body, there are 5 different points in the ear that you can put needles into. And there's a protocol that's been developed that counselors can be trained on to do this specifically for people who've got opioid use disorder and who are on methadone. So we found that by doing that, that also seems to bring some relief to patients as well. So my colleagues and I are involved in 2 of these HEAL initiatives. The HEAL initiative is part of the National Institutes of Health, this large initiative to try and reduce or tackle addiction, and specifically opioid addiction, in large part because the numbers of people who are dying from opioid overdose in the country are alarmingly high, and in fact gone up, not gone down, since the pandemic has started. So we've got one study called the CLOUD study, which is a longitudinal observational study where we're looking at patients who are at APT, who have an opioid use disorder, who are either on buprenorphine or methadone, and then we're getting a brain imaging at baseline, we're getting sleep studies at baseline, we're looking at their pain, we're looking at their substance use, we're looking at their psychiatric status, we're looking at their home environment, we're looking at social factors, and we're tracking them for 6 months. And we're looking at how does sleep intersect with pain, intersect with substance use, and all these other variables longitudinal over the 6 months. And then we're also about to start the APT Foundation an interventional study or a treatment study, where rather than observing people, we're going to recruit patients who've got chronic pain and who have an opioid addiction or opioid use disorder. And we're going to compare treatment as usual versus what we're calling a stepped care model. And in this stepped care model, we're training up frontline clinicians. So these are everyday counselors in these methadone clinics to deliver cognitive behavioral therapy for opioid use disorder and chronic pain. And if after a month or so the pain is getting better, they keep getting the CBT. If it's not, we're stepping them up to get on-site Tai Chi and on-site We Fit. And then if that works, we keep it at that level. If after another couple of months that doesn't work, we're going to step them up to also receiving auricular acupuncture and relaxation training. And essentially what we're going to do is offer them a treatment for 6 months, and then we're going to follow them up for 6 months more. And we're hoping that if this goes well, that we might have this treatment package that in some ways mimics what might go on at a fancy interdisciplinary pain clinic in terms of the interventions that are offered, but that would be able to be implemented in organizations that have a more of a shoestring budget. That's it for now. Those are my slides, Elinor.
Thank you very much. We'll come back to our face-to-face conversation. This is really just so interesting, the combination of different non-pharmacological treatments for pain, and the fact that APT is a home for this kind of research where you can shrink the time it takes an evidence-based practice to be brought actually to clinical care and affect people's lives. So that's very heartening that it's happening right in our backyard here in New Haven. I'm wondering, can you tell what's going on from looking at people's brain and people's brain waves with pain? Does it look different?
That is a great question. And there is some evidence that yes, right? So that there are cortical changes that take place when people have had pain for a long time. And that when you look at the projections from these brain images, that they in part explain why when somebody has chronic pain, that they're more likely to have poorer working memory, that it interferes with their mood. And I think in part, this is what makes this patient group difficult to work with, because they don't quickly get better. And many of our interventions approach chronic pain as if it were acute. When patients, for example, get referred to me outside of a clinical trial, often when they meet with me, they're miserable, they're angry, they don't want to meet with me. They tell me things like, this isn't in my head. Why am I meeting with a psychologist? It's over a period of time that I try and figure out, well, what's going on with you now, that what you're experiencing is real, right? Many of the patients who end up at somewhere like APT with an opioid use disorder have gone through pain programs where they say that the opioids they were given was the precursor to their addiction. So they often have a distrust of providers. So from my point of view, they're really interesting patients to work with. They have lots of they really keep me on my toes when I'm working with them, right? And that one of the things that I think it's really important for providers when you're working with these patients is to have patience, right? And not to be surprised if they're angry. And in fact, I much prefer to have patients coming in angry than it's the patients who come in and they're saying nothing to me and who are shut down. Those are the patients that I worry about the most. But the ones who come in and who are angry, and also maybe what I try and do, and especially with providers as well, is to look out for the small changes that can take place over time and to clue in patients to those changes. Because I think one of the things that happens to people who have pain is that they often focus on what's going wrong, right? And it's important. So part of what we do, for example, with the CBT is to train them how to be hardy. And we do some of the training that the military uses, for example, with veterans, about how to be hardy, because we view the pain as being somewhat traumatic, and how do you live with it? Unfortunately, there is no quick and dirty, because even last week, for example, I was part of a NIH investigator meeting where the focus was on opioid use disorder and chronic pain. And when I started off doing this work and I would go to conferences, I would think, oh, I'm going to go somewhere and somebody's got the magic bullet. And they're going to tell me that, oh, don't do any of this stuff, that really what I should be doing is this other thing. It turns out the magic bullet really isn't there, or at least isn't there yet, right? And from my point of view, it's even with the brain imaging stuff, it's unlikely to yield a magic bullet.
Well, do people come and hear you talk and think that you're going to have the magic bullet? And
yeah, so
yeah.
oftentimes patients do, right? And we discuss what's that like then, right? And what are they going to do with that? And what can they still, despite there not being a magic bullet, how are they going to deal with their pain, right? And that there are approaches to helping people manage their pain better. And usually when people feel like they can manage their pain better, that they report that their pain goes down and they're not as bothered by it.
Now, acetaminophen, you brought up as one of the three buckets of treatments for chronic pain. That has some long-term side effects, right? Or things that you have to watch out for. Can you talk about that?
So one of them being even like liver functioning. What tends to have happened over the years in pain medicine is that somebody comes up with a medication that lots of people start using, or prescribers start trying out, but then side effects come to the fore, right? So probably the safest ones in some ways so far are probably the SNRIs and the SSRIs, and also to a certain degree tricyclic antidepressants, that they seem to help maybe both with alleviating pain somewhat and mood. Because one of the concerns I think with these patients is that they're also at risk of suicidal ideation. And I think increasingly providers are tuned into that. So unfortunately, this is what makes in some ways these patients difficult to think about in terms of just one long-term pharmacotherapy that hasn't been the case so far. And that it's probably more the case that they're going to be switched up, that the regimen needs to be looked at periodically. And this is where having non-pharmacologic approaches, I think, can help the medications work as well, and the other way around. So I would not view them as being in opposition. I would view them as being in tandem.
In your role as a researcher and in research design, how do you distinguish between, say, for We Fit, between the efficacy of the activity itself and the social aspect of being in a group and just being among other people? And how do you tease that out as which is the most beneficial, or does it even matter?
That's a great question. So in the current study design, we will not be able to do that. Based on observation, though, you're right, that there's something about the social aspect, because one of the things that I have not gone over is that chronic pain can be very isolating, right? And that if you ask patients, how do you spend your typical day? Which is usually one of the first questions I ask patients when I meet with them, that many times patients will say that they isolate, that they're sitting on their sofa, watching TV. And even if you had a young, healthy person who's never had any problems, anything, and you say, sit down on your sofa, watch TV day in, day out, they will likely end up somewhat depressed, right?
Maybe achy. Yeah.
Yeah, right, exactly. So in part then, I think any of these interventions where you can overlap, benefits. So if you can, so even, when I'm doing treatment with patients and they're not walking this week, next week they agree to walk for a minute, the week after 2 minutes, that usually what I'll then start suggesting is, well, who can you walk with? Do you have a pet, dog, anybody who you can walk with, just to start building up social interaction as well? Because I don't think they're necessarily in separate buckets. I think they can overlap. And I think also an important part is maybe the therapeutic alliance between the clinician and the patient for me is key. That, I think one of the things that maybe Ming was alluding to at the beginning is that there probably are patients who've got a view of pain that's biomedical, and the only thing that's going to work is a medication, or right. Whereas if patients are coming in to see me, they're going to be sorely disappointed because I don't offer them that, right? I usually offer them something else. And I think one of the reasons I pay particular attention to a therapeutic alliance is that they'll give me the benefit of the doubt. And that when I suggest that they try something, that they just don't go, that guy is an idiot and he doesn't know who I am, that I try and build up an alliance so that they are willing to try something. And then what I try and do is get them to do something that's exceedingly small, where it's going to be very difficult for them to fail. And one of the reasons why we try and do things at the clinic is that, most of these patients are coming in routinely for medication. So why not have them do something else while they're in the clinic? Why not have something available for them that's going to be engaging and that they might get some benefit from? And there's also probably some group of patients that the social interaction might be too much. So then even something like group auricular acupuncture, where you get people in a room, you sit them down and you put needles in their ear and you tell them to stay quiet, right? And you tell them to relax, that there are some group of patients, I think, who can tolerate that. And that in and of itself can be the first step towards even doing something more interactive.
Now, people doing other things while they're coming in for their opioid treatment seems like it might have, and maybe you said this earlier, just to reinforce long-term beneficial effects on staying in treatment.
Yes.
Right? And having the opioid disorder arrested for maybe a longer period of time. Yeah.
And one of the things that we're looking at in these studies, especially in the step care study, is do they stay in treatment longer if we address their pain? And our hypothesis is that yes, they will, that they'll see that their needs are being met more and that they will linger more in treatment, but we'll see. That's the hypothesis.
Great. Well, we're going to take another question from Ming, and then I've got a final wrap-up question.
Sure, yeah. I don't know how well the people with chronic pain are covered by medical insurance. So in your case, when you look at the patients, what if the patient doesn't have medical insurance? do you choose to treat this person, or do you just have to let this person go?
That's a great question, right? And it says something about our country that's a really important question, right? That there's probably something flawed, even though we're spending a lot of money in our healthcare system, that a lot of it does come down to reimbursement. The way that methadone clinics are set up is that there's often a bundled rate. So if you're a director of a clinic and I'm coming into your clinic as a patient, you're getting a certain, especially if I'm poor and I don't have insurance, that you're getting a certain amount of money for me. And that whatever you provide for me needs to be within that bundled rate. So what we've deliberately then tried to do is to come up with really inexpensive interventions that with the bundled rate that clinics would go, okay, yeah, it's going to cost $1, $2 for each person for this group, that we can do it, right? So that's exactly one of the reasons why the groups that we've come up with is to address that point.
Outstanding. So glad that came up. Thanks, Ming. Now, what do you foresee as next? When you look around the world at all the research that's going on, when you think about kind of the frontiers of treating this intersection, what juices you up?
One of the things that we're going to look at next, hopefully, is sleep, right? And that we're going to try and target sleep. Because when we've looked at the sleep of patients who've got chronic pain and opioid use disorder, there's people who do the sleep studies are just aghast about how broken up these patients' sleep is. And that if any of you have not had a good night's sleep for 3, 4, 5, 6 days in a row, and this is happening week in, week out, that I think it's got a negative cascade of sequelae. And that there are many patients who don't want to talk to me about pain, or who don't want to see somebody like me. And that it's probably less stigmatizing addressing sleep. So one of the next things I'm going to hopefully look at is sleep. And I'm going to say to them, let's target your sleep. I won't pester you about your pain. And let's see what happens to your pain, right? Then there's also a whole group of exercise interventions that are being tested out around the country. Different types of exercise, from Tai Chi to yoga. One of the things though that I wonder about that is how easy is it going to be for people in rural Appalachia, for example, to access that, right? And this is one of the benefits of medications. And then there's a whole series of medications that are addressing things like sleep, anxiety, depression, not even necessarily pain. And the National Institute of Health are spending a lot of money on medications that are allegedly non-addictive and that don't involve opioids. And I think that hopefully will hold some promise as well. Because it's one thing with somebody like me saying that, the gold standard is this interdisciplinary. I think for many patients that their model of illness is biomedical, and that what makes sense to them is to have a medication. So it would be great if we had medications that had a lower risk of addiction and that had lower side effects. And I will be all for that.
Well, you raised some really good points, and clearly more research is needed. So I'm glad you're around, and your team and your colleagues. So I want to thank everyone again for coming. These community forums are designed to give a window into how interrelated all the different departments are within APT, and to invite you to think about those active studies when if you're in clinical settings and treating anyone, or if you want to learn more about how to get involved in one of those studies, you can contact the APT Foundation on its website, aptfoundation.org.
Declan.
Thanks a lot, everyone.
Yeah.
Bye.
Thank you all for your time. Bye.